Welcome today to our third CVMA Weekly Town Hall, Navigating Through COVID-19. My name is Melanie Hicks and I'm the president of the CVMA and the moderator of this session. I'd like to take a moment to thank Hill's Pet Nutrition for generously sponsoring this Town Hall series. I am joined by our host, Dr. Scott Weiss, who many of you are familiar with. He's a professor at the Ontario Veterinary College, a director at the University of Guelph Centre for Public Health and Zoonoses, and chief of infection control at the Ontario Veterinary College Teaching Hospital. I'm also delighted that we're joined today by Dr. Catherine Falaski, who is the new president and CEO of the Canadian Animal Health Institute. Some of you may remember Catherine from her previous role as the Ontario Ministry of Health's Public Health Veterinarian. She'll be presenting today on CAHI's recent work on guideline development for industry interactions. Before I hand it over, I want to ensure that everyone knows that this session is being recorded and will be posted on our website. We have the two previous sessions recorded, so if you've missed them, you can certainly go onto the CVMA website to check them out. We have muted all participants to ensure that everyone has the best audio experience, but I would encourage you to keep your chat box open. We'd love to have your feedback, questions, and comments that we'll address today as time allows or in an upcoming session. Ideas for future topics are always welcome, and I'll be monitoring the chat box and we'll pause to answer some of these questions along the way. Just please ensure that you do send it to everyone, not just the CVMA. And with that, I'll turn it over to Scott.
Great, thanks a lot. I'll just get my screen up here. Find the right one. All right. So thanks for coming out again today. We've got a couple topics, as you've probably seen, and as per normal, we want to make this as much question and answer based as we can. So give me a second here. Okay. General comment, if you have any questions about this material or COVID concerns in general, feel free to track me down, put urgent in the title to make sure I reply quicker. Never hesitate to contact me. So what we're going to talk about is just a really quick update on the status of this virus, not like a big detailed update about it in people, but where we are as that relates to what we need to do. Consideration for clinic visitors is going to be our main topic. There'll be a little bit of a refresher on some of the things we need to be thinking as we move forward. And I guess the overall tone for this presentation is, what do we need to be doing proactively as we start to enter the next phase and hopefully stay in that next phase, which is a recovery phase. And the more proactive we can be, the better, because we are going to have various challenges and requirements as this goes through. And like always, we'll pause for questions quite regularly, and please send them through the chat if you want to raise your question here. So just a quick, where do we stand? Here are the numbers from Canada. I'm not going to go over them in detail. They're an underestimate by far because we don't test everyone that's sick. They're biased towards long-term care facilities and healthcare providers, but the numbers continue to increase. If you look at provincial numbers, Ontario, it seems to be plateauing. Hopefully it'll maintain that way, but everyone's looking at the numbers, obviously, and more importantly, we're looking at the numbers of severe illnesses. But this is a question that came up the other day, and the question kind of started off with, are we at the point where we're going to have herd immunity and we don't need to worry about these things? And the take home is, we're nowhere near that yet. We're not anywhere near a level of population protection we're going to need. So if we have 71,000-ish cases, right, that puts us down this graph on the left. The blue line you can't even see is the percentage of the population that's protected, assuming that a recovered individual is protected, which is still an assumption. If we say 10 times underdiagnosis, or even 100 times diagnosis, right, if we've got 100 people that are infected for every known case, we're still very low overall in terms of number of people that have been affected. And we don't know what that magic number is going to be for herd immunity. Like I said, it's probably not the high 90s like measles, but it's probably not 30%. So 67, 2/3 has been talked about as a target before you really start getting good herd immunity. But we don't know. But the take home is, we're well away from that. And we'd rather have a vaccine produce that than natural disease. Because if natural disease does it, a lot of people are still going to die. And again, the general take home is as things start to open up, which they are doing, it doesn't mean that things are winding down. And that's something we just need to be diligent about, right? It's easy to start thinking, okay, well, we've made it over the hump. Things are good. I don't have to do what I've been doing. It's not as important. Well, yeah, it is. Because essentially the take home of opening up means there's room for you in the ICU. There's a ventilator for you if you need one. Because the main goal for all of this is to keep disease below, severe disease rates below ICU capacity. You know, we'd like to prevent disease overall, but that's the magic number. It's hospital capacity versus number of cases. So things are improving, hopefully, but this isn't something that's going to be done very soon. Okay, so just on the animal side, not a lot really to report on new things this week. We've got some, you know, just some follow-up information. I mentioned mink before, just a few more mink farms in the Netherlands. Not a huge issue for us in Canada. We don't have a lot of mink farms, but we do have some. The other issue is ferrets being very closely related to mink, and we know that ferrets are susceptible. We know that ferrets can transmit it ferret to ferret, just like mink were transmitting it mink to mink. The public health risk isn't really known. If we look at these farms in the Netherlands, there was mink-to-mink transmission. Ultimately, this is a human origin disease, and like all our animal issues, these are human origin. There was suspicion disease would be more severe in pregnant animals. Heavily pregnant animals they thought were more severely affected. And they found virus in dust samples in the barn. And, you know, this isn't something really to freak out about, I don't think, at the farm level. We can find lots of things in dust samples. You can find MRSA in pig barns. You can find various things because they get on dust particles that get liberated. We have no idea if it's infectious virus, but it does reinforce some concerns for going on to farms that have mink on both aspects. If you are one of the small number of people that's going into a mink farm, we want to bury ourselves from the animals so we don't infect them, so we don't have to worry about that risk, but also, you know, precautions for us would make sense. There's an infected cat in Spain, classic story, sick person, cat became infected, cat died, but had cardiomyopathy, so it wasn't thought to be the cause of death. Not really much more on the companion animal side. There's not been a lot of animals tested that we've heard about in the interim. There is some testing going on. Our surveillance of animals in contact with infected people is going on. No positives yet, but the testing is not very far advanced. So we really don't understand the scope of the issues with companion animals. Wildlife handling, there's been some discussion, more and more discussion about wildlife, and that includes, you know, bats, urban wildlife, marine mammals have been talked about lately. And really the big issue there is preventing us from infecting them. So there are some guidelines that have come out from some wildlife groups, some you know, pest control groups about personal protective equipment. But ultimately what we need to remember is we're worried about us infecting wildlife populations. So if you're working with wildlife, then using the protective approach of taking things to prevent us from infecting that animal is what we want. Because we don't want to infect a wild animal and have it go out into the wild and pass it on. Animals that are coming in for euthanasia or wildlife are a different story because we're not worried about infecting them. The risk to us from wildlife is probably exceptionally low, but it's that concern of establishing it in wildlife. So bats are a big concern. So there are active efforts to discourage any type of bat research involves going in either bat caves, having contact with animals. There's been discussion about things with marine mammals. There's been some theoretical concerns about the virus in sewage in marine mammal populations that live close to urban populations, because sewage is being looked at as a proxy for infections in the population. So if you look at how much virus is being shed into the Guelph waste treatment plant, it gives you an idea maybe of the community burden. So there are a variety of issues that are coming around. You may see them, you may get people. They're more very much precautionary approaches right now, but just again, reinforcing, limiting that human-animal contact so we don't have to worry about it. Right? If we don't expose animals, I don't need to worry about whether they're infected or infectious or what I need to do. I'm not going to talk about this much more. We introduced this last one. This is there's a document we produced, and it was sent out through the OVMA, I think CVMA. It's on our Worms and Germs blog. It's thinking where term. We're not going to be back to normal the way we operate clinics next month. We need to be thinking about these general concepts, and we're not going to get a list of things from a regulatory body or a government saying you have to do, you know, this. You have to be this far apart in your clinic and this number of people in your waiting room. But I think the expectation will be concepts. And we've gone over those in the document. If you haven't seen it, again, you can find it on our Worms and Germs blog or various places. But things like physical distancing that we're going to have to maintain. And this is something that we need to be thinking about proactively in clinics, because we're not just going to open the door and have people come in like normal. We need to be thinking, once we get to the point where people are coming into the clinic, clients are coming into the clinic, you know, what's your waiting room capacity? What's your waiting room layout? Do you have plexiglass shields that are going to be installed to protect your personnel and prevent things from your front office staff? There are a whole range of issues. Essentially, go to your grocery store and look at what they're doing and figure out which of those apply to you. Lines on the floor to keep people distanced from your front desk. How do we direct flow and to reduce that close contact? Because ultimately what we're trying to do is reduce these situations where we have less than 6-foot barrier. So physical distancing is a huge thing we need to be thinking about in clinics, and it's something you should be thinking about now because it lets you prepare for the point when you do start letting people come in, letting clients come in the clinics. You know, alternate service delivery, telemedicine, we've talked about that before, self-monitoring being a critical thing, cohorting individuals. Again, the whole thought that if you get a positive person in your clinic, is everyone exposed? What are the implications for your clinic from a public health standpoint if they investigate a positive person? Personal protective equipment, and this is a long-term thing for us, right? What are we going to be wearing routinely in clinics for close contacts with clients and with colleagues? And I think it's very common now in clinics that cloth masks are standard for any type of situation where there's going to be a 6-foot barrier breach, or just all the time in clinics, because those happen when you walk around a corner. But I think thinking about your PPE approach and your supplies when it comes to personal protection of your staff is really important. I've told people like there are multiple clinics in Ontario that are shut down because of COVID infections amongst the staff, outbreaks amongst the staff, where one person was infected, spread it to staff. So this is a real concern. You know, this is more than just the theoretical concern. Yeah, someone might spread it. We are getting transmission in clinics, and it's resulting in clinic closure. I'm not going to go over all these different things, but these are the areas we need to think about, and I'm happy to chat about them later on. If there are questions, absolutely, we can get to those. Maybe I'll just, I don't know, pause here, Melanie, if there are any questions to get started, then we'll move on to our main topic, which is different people coming into the clinic. Let's see if I can see the chat box.
Yeah, so far we don't have any questions. For anyone who's joining just a little bit late, please feel free to bring any comments and questions forward in the chat box, and just make sure that you're sending it to everyone.
Okay, so thanks. The main topic we wanted to hit beyond, you know, thinking about moving forward in your clinic setup is your operations for people coming into the clinic, because we're doing a very good job now, I think, in general, of distancing from clients. We're doing not quite as good a job, but I think overall we're doing a reasonable job distancing within the clinic with colleagues. But if you think about how we normally operate, we have a lot of other people that come into a clinic. And ultimately, you know, we want to have those restored. We want to do it safely. And we need to be thinking about this now. Again, the more we can be thinking about it in advance, the more we can coming up with protocols, whether they're clinic protocols or broader protocols. But really, again, it's that level of expectations. It's not necessarily a recipe book that someone's going to say you have to do these exact points, but it's more general concepts, and I'm going to get to that. But things we need to think about when we're thinking about bringing people into our clinic that aren't there on a day-to-day basis, because every human-human contact increases the risk. The more people we interact with, the more risk. The fewer the barriers, the more risk. The farther they are away from us socially, geographically, microbiologically, the more the risk. And as we start bringing different people in, you know, we inherently are going to increase the risk. So we need to figure out how to balance that. So some visitors obviously start thinking about the list, and this isn't the whole list. And farms have some different issues too. But you know, veterinary students, technician students that might be doing placements, co-ops, externships, external electives, summer work, volunteers, co-op students, industry representatives, and that's going to be where we're leading into next, and various other people that might come in. Slides won't work. There we go. So general concept, you know, this is pretty basic, but if we can think about what increases risk and what decreases risk, we can think about how we can mitigate risk, right? What can we practically do in a clinic, or are the situations and times when we're just going to say, no, it's not worth it because I can't do it and the cost benefit's not there. So thinking about the cost benefit of these interactions is important. Thinking about how much extra risk this particular interaction poses, and then what we can do to reduce that. And again, these are kind of high-level concepts, but you know, it's common sense. What increases the risk? Well, more people, right? One person coming in is one thing. 10 people coming in is, you know, 10 more exposures. But of those individuals, what increases the risk? Well, someone that's had contact with a lot of people. If someone's been socially distanced really well and they don't see a lot of people, that's a very different risk than if it's someone that routinely sees a lot of people. And as we start to get back to normal operations, we are going to see people that routinely see a lot of people coming into our clinic. And that'll lead to the industry talk next. Visitors that are farther away geographically, right? So doesn't necessarily mean, you know, they came from 2 hours away, so they're much higher risk, but you know, if things are contained in your area and they're coming from an area where they're less contained, that may increase the risk. In general, you know, movement increases risk of any disease. The farther the movement, the more risk we can run into. And then the obvious one is duration of contact and closeness of contact. The amount of time they spend in the clinic, how close they get to you during that time, and things that are happening, talking, coughing, things that can produce more aerosols than just sitting there quietly in the corner. Things that reduce the risk, well, it's control the visit. So yes, no, does the visit even happen? Where does it occur? How does the personnel flow work? Do they hang out here, go here, go here? Do they get admitted straight to an area where it's all choreographed? A lot of the stuff that we're doing is basic choreography, right? Whether it's clients or whether it's us or whether it's visitors, it's having a plan in place for how that person moves so they do as little movement and as little interaction as possible, just the amount that's needed. So how is it done? What's the timing of it? What procedures occur? And visitor contact history. So thinking about some of those factors that come in before and what you're willing to accept in terms of your clinic risk. And it may vary between clinics, right? You may be more risk averse inherently. You may think it's more important to have them come in. You may have higher risk people in the clinic or at home that might alter your approach, but we can still have the same general kind of thought process. Maintaining distancing, obviously. That 6-foot barrier is not magical, but we're worried about droplets and aerosols. So if we keep 6 feet away and we have cough etiquette, that'll help a lot. If someone is sitting there and they're talking and they're trying to project their voice in a presentation, then they're projecting more droplets and more aerosols. So 6 feet maybe is very much on the limit if you've got a speaker. So thinking about someone's doing a presentation, how much space they're going to have versus your general chat. Personal protective equipment. So what are you going to wear and what are you going to require them to wear? If you're a clinic, you can set the rules, right? If you expect them to wear a cloth mask, you can expect them to wear a cloth mask. Syndromic screening, and that's just a good communication thing. So if you're sick, don't come. That's always, somewhat been the rule, but I think we realize now that really has to be the rule, that, these are the things that if you have this, you shouldn't be going into a clinic. And then something that deals more with, maybe externship students, longer term things is, the more distance they've traveled, the more risk they have. So if you've got someone coming in for an externship and they live down the road and they've been doing a very good job of socially distancing, well, they're posing very little risk. If you're in Ontario and they're coming in from BC or Quebec or somewhere else, then that geographic risk is different. They've got travel, which exposes them to a variety of people. They've got a whole pile of risk factors coming up. So you might want to think about a 14-day exclusion, which is getting very common, I think, in various industries. Not something you're going to do for a drug rep making a visit, but something we can do for a longer term stay in a higher risk situation where 14 days is practical. So these are all just the things to think about. Ultimately, I've said this, I think I already said this today, but this is one of the things to think about. So if you got a positive person in your clinic, it doesn't matter who it was, how confident would you be talking to public health saying, yeah, we're good? Right? This is what happened. Here are protocols and here's what they did. So we weren't exposed. So don't worry about us. As opposed to them coming in and not really knowing what they did. You had close contact, you weren't barriered, and you run the risk of them saying, okay, well, you're all exposed. Everyone go home for 2 weeks. So, the more we can have this structured, thought out, the better the case, just to prevent us from getting infected, but also to prevent the clinic from being closed if there is a response that says, okay, close the clinic because of exposure. So that leads into Catherine, so I'll let her take it over from here.
Thanks very much, Scott. So for those of you who may not be as familiar with what the Canadian Animal Health Institute is or does, we're actually the industry association that represents the vast majority of Canada's pharmaceutical and biologics companies on the animal health side. And we also sort of have within our membership scope distributors like vet purchasing, associated vet purchasing, and a number of other sort of associate tier membership organizations like the Association of Vet Techs in Ontario, et cetera. So we represent sort of a very wide range of the veterinary sector within Canada. But essentially sort of what I wanted to speak to you about today was what industry is really doing to prepare for the complexities of reopening. Because much of sort of what Scott has already referenced in terms of the concerns about the impact of having someone who is identified as COVID-19 positive within sort of industry's operations, it sort of extends much further and becomes more complex once the industry's field force starts to head back out and starts to have interactions. So for that reason, industry and individual companies have certainly been working on the preparation of their own sort of operational plans through the reopening phase. And certainly nobody's going to be going from 0 to 60 overnight. It is very much going to be sort of a gradual process. Within individual companies, certainly all of the multinationals have formal teams that are in place who've been working on this for 6 to 8 weeks now. And the way that works is they incorporate sort of their global requirements first that come from the international sort of mothership offices. And then local country requirements are overlaid on top of that, including legislative or logistical essentials. And then superimposed on top of that is the customer framework. What CHI is now doing is working on an industry-wide guideline to support harmonization of all of these plans that the individual companies have been working on in the Canadian context to come up with some way of making the approach relatively consistent so that vet clinics are not dealing with different sales reps or drug reps or technical veterinarians who are coming from different companies, and everybody's doing it a little bit differently. So the idea really is to prepare and plan for field staff operations through several phases of reopening over the coming months, possibly year or more. And that includes providing a standard set of recommendations to support that kind of operational planning within the companies. The focus is really on ensuring that potential risks of human-to-human transmission of COVID are managed and minimized as much as possible, while continuing to provide support and service to veterinary hospitals, practices, producers, et cetera. And I'd really like to just emphasize that industry is very much together in terms of wanting to stress that the entire process of when reps are allowed to come back into clinics is really sort of dependent on the veterinary profession's comfort level with that. And part of this work that we're doing right now is to communicate and generate awareness of the kind of measures that industry will have in place to, again, ensure that any reps that would be coming into practices or into see producers or to feedlots would be following a very sort of strict set of measures that would minimize sort of any risk of disease transmission. Can I get you to flip the slide, Scott? Thanks. So I wanted to sort of give you a bit of an overview of how this work in terms of harmonization of various individual sort of companies' plans and approaches to this is being harmonized. What we have started with at the industry-wide level is, first of all, collecting input on the kinds of operational questions and concerns that member companies have. So what kind of things do their sales reps and technical vets want to know in terms of how are they going to be doing things? What are the challenges that they see from their perspective that need to be addressed? We're also gathering input from the veterinary community, both from veterinarians and the vet tech community. And for that reason, I'm really very appreciative of this opportunity to come and speak to you today, to sort of solicit direct input, both through Scott and his experience of questions that he's gotten from everyone else, but also to encourage you to certainly sort of direct stuff directly to us as well, if you feel comfortable doing that. We've also reached out to feed mills. We'll be reaching out to the producer community, and also consulting a number of associations that are dealing with similar questions. So most notably, really sort of our human health counterparts on the pharma side, which is Innovative Medicines Canada, who are taking a similar approach on the industry side in terms of coordinating how individual human pharma companies are going to be dealing with the question of how do they mobilize or start to mobilize their field sales force again to go see physicians and other regulated healthcare professions. We will take that initial input and CHI will essentially sort of draft a set of, an initial set of guidelines. We will be consulting and getting input from public health authorities on those, from occupational health and the human health sector, again, primarily working in concert with Innovative Medicines Canada. We will also sort of be looping back into the veterinary community periodically to sort of get your input on the format and the content that we are having and developing. And all of that has to be informed by identification of the relevant federal and provincial guidance for workplace settings. The complexity there obviously is that all of the provinces have a slightly different way of doing this. All of the provinces have issued different sets of guidance. New Brunswick, for example, has specific guidance for dog grooming facilities. We have nothing like that in Ontario, but we are sort of doing an environmental scan of all of sort of various pieces of guidance that is coming out for workplace safety and prevention around COVID, and trying to sort of fit that into a fairly standardized or harmonized framework. So CHI work as the hub of and the main workforce to sort of put all that together with extensive consultation going forward. And the result will be this sort of CHI or Canadian Animal Health Institute industry guideline that companies can then use to refer to find a common approach within the Canadian context, and to the extent possible, align their own sort of operational plans with that. I will say that having heard from our board, which includes sort of all of the really big companies in Canada, they're very much looking to this industry guideline as a source of guidance and as a source of providing feedback back to their sort of international headquarters in terms of what the Canadian context requires. Next slide, please, Scott. So just to give you an idea of the type of approach that we're taking and the types of issues that the guidelines will definitely be including content on, we are looking at sort of a phased approach, probably at least about 3 phases. This isn't written in stone yet. But really sort of looking at guidelines to inform operational requirements and operational activities through an initial phase where there is an initial receptivity to having industry reps coming back into contact with veterinary hospitals. Phase 2 would be looking at the next sort of period where there is increased customer receptivity to increased contact and perhaps sort of larger meetings, larger gathering sizes being allowed. Again, a lot of that is dictated by provincial phasing in of easing of restrictions. And phase 3 is really sort of kind of a stabilization phase of what is the new normal at the tail end of COVID response before we go back to sort of totally normal if we ever actually really do. The main sort of buckets of issues that we're addressing is all kinds of things around sort of social distancing. So examples of that are to what extent will industry have their reps continuing to connect remotely versus starting to reintroduce some in-person calls. What are the minimum requirements that reps really need to ensure are being met to ensure that appropriate social distancing is feasible, both within their home offices and when they're out back in the field. And particularly what happens if a rep is exposed to a COVID-19 case. And these are by no means an exhaustive list of things. I'm just giving you a few examples of things that sort of fit into these buckets of issues. The travel question is a big one, as Scott mentioned. Certainly sort of the farther away someone is traveling geographically, that poses unique challenges. So there will be guidance around things like how far reps are permitted to travel in which phase of reopening, how frequently are they allowed to travel, when are they allowed to travel, and certainly distinctions being made between local versus interprovincial travel based on sort of territorial sizes. There will be a lot of attention and focus to awareness of and adherence to local jurisdictional restrictions on travel. So in particular, even though a province may be reopening, there are regions of the province where travel is still sort of really restricted, or there are heavier restrictions in place. So if you're looking at the Quebec context, the difference between what's happening in Montreal versus what's happening outside of Montreal. There will be certainly recommendations around avoiding hotspots of COVID-19 transmission. Looking at appropriate modes of transportation for reps. For the most part, there will be no use of public health transportation recommended. So reps would be traveling sort of in cars only, no plane travel, et cetera. And looking at sort of restrictions around overnight stays. Field call protocols themselves is the third sort of main bucket, and a lot of thought is being put into things like restricting the number of calls that a rep could be doing per day. Protocols for infection prevention prior to entering any premises, whether it's a veterinary hospital or a feedlot or a producer's facility. Policies around things like ride-alongs for industry staff, coaching days, and restrictions likely on the number of reps attending a single call, which would progressively be eased as we get through to sort of the later phases of reopening. PPE is another really huge topic. What kind of PPE will reps have with them? What will be provided to them by their companies? N95s versus surgical masks versus cloth face masks. Where is the use of which one's appropriate? The management of things like clothing and shoes in between calls, if reps are permitted to make more than one call a day, and certainly sort of how they are managing their clothing and shoes between their home environments, if they're still working remotely for the most part, and any field calls that they may be making. Hand hygiene supplies and protocols are sort of lumped into that category as well. Meeting protocols is the next one, and that really has to do with looking at limitations on any kind of meeting sizes. So what meeting size is appropriate in which phase of reopening, and there will be some consideration of things like what is sort of the capacity within a given facility to facilitate or to allow meetings of 2 people versus 3 people versus 10. And all of that is based on sort of the ability to ensure that you have enough room to have that 6 feet, 2 meters in between people at any kind of meeting. So meeting room size requirements. The question of providing food at meetings. So some of sort of the really common practices, particularly around things like lunch and learns, use of restaurants or delivery of food. There would likely be a lot more restrictions on that in the initial phases of opening, because it introduces a level of complexity in terms of complying with guidance from the provincial governments around things like delivery services and minimizing transmission there. And the thing that is unique to a little bit to animal health that we don't find on the human pharma side is the issue of biosecurity. So in particular, the animal dimension introduces sort of a little bit of a different element to our human counterparts. So things like sort of really managing industry rep contact with animals on field calls, and how to ensure that biosecurity protocols, particularly in the livestock sector, are really well integrated into the COVID-19 protocols. Next slide, please, Scott. So why am I here today? The ask from us as industry to you as the profession more broadly today is twofold today, really. The first thing is we welcome any suggestions you have for how we can build awareness of and comfort with industry's development of guidelines for managing interactions between industry reps and veterinary hospitals or practices or clinics, whatever your sort of practical clinic setting is. We would love to hear what your questions or how you think we can continue to gain input from the veterinary community, particularly over the next week or two as we really sort of move forward on developing these guidelines. Secondly, is a request for your input with respect to the questions and concerns that you have within your clinic setting about future interactions with industry representatives. Particularly sort of what are specific limitations that you would see within your own space. And you can certainly submit those questions, concerns, and suggestions to us at the email that you have there on the screen. I know Scott has really generously offered also to field or direct anything that can come in through the Worms and Germs blog and any of his channels as well. So we're really looking at trying to funnel all of this information into the appropriate channels and to work well together in order to do that. I think that was my last slide, Scott. But I'll maybe hand it back to you. And Melanie, I don't know if you want to sort of see if there's any questions that either Scott or I can answer with respect to the last few pieces.
Sure, there's a few different questions that are coming in. The first one, I guess for you, Catherine, any insights into the timeline for completion of the draft guidelines, and will they differ by province based on the current COVID status?
So I think the timing, we're really looking, I think, to try to have something out by June at the very latest, beginning of June would be my guess. We're very conscious that even as sort of provinces start to reopen right now, it's unlikely that people will be really comfortable with just throwing the doors open to have reps coming in right now. We can tailor that a little bit if we find that sort of things start to speed up over the next week or so. Then you know, we're just going to be working some longer hours. But we also want to make sure that we leave ample time for consultation in that process, and particularly consultation on the content. And again, sort of giving people at least a few days at the beginning here to think about questions or issues that they would like to identify or to raise. Will it vary by province? So I think the idea right now is to structure the guideline in such a way that with the identification of sort of at least 3 different phases of reopening from an industry perspective, that will give the guideline enough of a flexibility that you could have Ontario, who is only in phase 1, and sort of operations within Ontario are limited to the restrictions under sort of what we would consider phase 1, that initial opening period. But someplace like New Brunswick or British Columbia may be at phase 3, right? So the idea is to try to provide something that is flexible enough that it has categories of practices that can then easily be adapted to whatever stage the overall process is in a given geographical location. The emphasis also is that there needs to be recognition that even within a province, you may have jurisdictional differences as a result of municipal decisions around business opening. So it's a bit of a daunting task, but I don't think it's impossible to create something that provides a gradation of guidelines that will allow sort of the field to use them as they can within a very differing landscape within Canada.
Great. And there's one more question for you, Catherine. In terms of visiting clinics at the end of the day, reps will need to comply with clinic-specific policies and protocols, correct?
Yes. So again, a lot of this is really driven and will work in concert with what customers need and want at that clinic level. You know, as much as if we can get as much of that kind of input around, if there are things that are very common, it's easier for us to put them in the guideline, but there will be specific language in the guidelines around you know, ensuring that the customer's needs and requirements are being met at that individual clinic level, in addition to, you know, what the company-wide and the industry-wide recommendations are.
Great. Thank you, Catherine. Did you want to answer some questions now, Scott, or did you have any other material to present?
I think we can jump into questions. Actually, there's one comment that comes up from something that Catherine said about N95 masks. One thing I've run into a bit is some people have N95 masks, and that's fine. You know, again, thinking about why we're using masks. So if we're using masks in a clinic, typically we're using it to protect from the user, right? So if we're wearing cloth masks, we're protecting. So if that one person is infected, they're not infecting everyone around them. And N95 is quite functional for that too. It's a high filtering mask. Those are, you know, try to reserve them for situations where we're preventing exposure of ourselves along with eye protection. But the one thing to be aware about with N95 masks is the masks that have the exhalation valves, the little plastic thing at the end, those send unfiltered air out. So they're designed to make it easier to breathe out. So they're designed as a way to protect you. So if you're wearing an N95, so if everyone else in the clinic is wearing a cloth mask to prevent from exhaling the virus, and you're wearing an N95 with a filtration, with a filter on it, you're actually not joining in the protective party there, right? You're sending out unfiltered air. So again, thinking about the PPE you have, so cloth masks protect people from you. Surgical masks would do the same. Regular N95 masks without a filter will protect from you and also help protect you because they're better filtering. An N95 mask with an exhalation filter is protecting you, but is not protecting others. So hopefully that's clear. If that's not clear, feel free to send me questions, but it's something that I've kind of run into a little bit lately because people do have sashes of these around. So I guess we can just head to general. Actually, I had one here from the other day I didn't end up using. So if a staff member is infected and is recovered, is it basically business as usual for them when they get back to the clinic, or do they still need to use PPE? So if we're all using cloth masks to protect everyone from everyone, if we have the infected person, do they have to join in? And you know, right now we would say yes. because we just don't know enough about immunity to say that that person is absolutely protected. The other thing is, protective immunity isn't necessarily sterilizing immunity. So you might have been infected, you might get exposed again. Maybe you have immunity to prevent you from getting sick, but maybe you're still able to get infected and become infectious. So at this point, standard guidance still is, even though you've been infected and you might be protected, we are still expecting everyone to do the same thing. It gets into a lot of discussion, immunity passports and all the controversial issues right there. But at this point, if you have an previously infected staff member, it's still best just to treat them like everyone else.
Great. So the next, or the first question, if we back up a little bit, are there any measures that need to be taken to protect ourselves or our staff from infection in handling the coats of animals?
Yeah, that's kind of something we've gone over a fair bit. So there are various documents. So a couple of things, there are a couple of questions relate to risk, and we aren't going to have time to get into all that. We have a lot on worms and germs blog. And we also have a document that was made up by a national group that I think CVMA sent it out last week, an updated version. It's on our worms and germs blog. It goes over a lot of the risk concerns when it comes to animals in terms of animal disease and human disease. So a lot of that stuff is covered in there. The short answer is we don't know for all these really well. For a fomite concern, theoretically, there's still a concern if someone's infected and they cough on, breathe on, pet their animal, and then you handle it right away, that might be a transmission point, just like any other environmental surface. The virus probably survives, minutes to hours, not days on the hair coat. But we're the ones that are most likely to be exposed to that. If you have an infected owner's cat coming into you, cat, dog, whatever, coming into you, within minutes of them having contact with the animal at home, then there's potentially some risk. And that's why we're flagging animals from known positive households for extra PPE on the assumption they might be infected or they might be contaminated. And I guess that leads maybe to another question was up there about asymptomatic infection. So that the big weak link with using the approach to say, okay, we're going to flag known positive households and treat those animals differently is the fact that we don't know all positive households because not everyone gets tested and because of asymptomatic infections. And that's just an inherent weak link. Ultimately you could say we're going to treat every animal like it's coming from a positive household. The incidence of infection in the community is low enough, it's probably overkill, and you burn through a lot of PPE. So it's cost benefit of saying we're going to treat every animal that comes in like it's covered in SARS-CoV-2. Sure, you can do that, and it's going to offer some degree of protection. We have no idea how much protection, but there are going to be some risks with that. And one of the big risks is you use all your PPE. So then when you do get the high risk case in, or the animal with Campylobacter or Salmonella or whatever, we don't have PPE left. So we increase our risk ultimately. So that's why we're still focusing on the known high risk situations, just because we don't really know what the risk is. And, bang for buck, and the animal coming from a known high risk household, we know supposedly some theoretical risk. The animal coming from a household not known to be positive, we have to assume it's going to be lower overall, even though it's not zero.
So the next comment or question, are you aware of a report out of Iceland, which was reported on 680 News this morning? It was based on 17 studies worldwide, stating 33 to greater than 80% of people are being infected by others who are showing no symptoms of COVID-19 and not even aware they're carrying the virus.
Yeah, it kind of ties into what I was saying before, is we know asymptomatic carriage is fairly common. What the number is, we don't know whether it's 10% or 90%. Doesn't really matter. There are a lot of people that are asymptomatic. The general assumption is that someone that's symptomatic is probably higher risk. Maybe they have a higher viral burden, and if they're coughing, they're dispelling it more. But it's been shown that just breathing with an asymptomatic infection, at least model-wise, will pose some risk. If you see most of the outbreaks where they've traced it to a person, you have the choir, where a bunch of people infected or a restaurant, usually those are symptomatic people, but all the reporting is biased towards looking at those known symptomatic cases. So ultimately, you get to the point where you can only do what you can do. So we can say that we're going to treat every person on the planet as infectious. Well, that's, from a control standpoint, that's the best way to control it. But from a practical standpoint, is that something we can actually functionally do? And that's one I ultimately take time, and we have to bring in social distancing because we have to live our life to some degree on the assumption that everyone's maybe infected. And that's why we do the mask use for healthy people and the distancing and everything else, but not take it to the extreme I think. So we're trying to find that balance of doing some practical things that will protect us from the asymptomatically infected person. So if you're going onto a farm, that's distancing and finding out who the low risk person is there. In a small clinic, it's, you know, it's curbside delivery and it's wearing masks to keep us away from colleagues to drop that risk, but we're never going to eliminate it.
So we have 1 minute left in the session and there's 4 or 5 different comments and questions. I don't know if you want to take a quick scan, Scott, and answer one last one that you feel is the most pertinent today.
Yes, maybe with the respiratory, the N95 mask comment, basically what the take home is, if your N95 mask has an exhalation valve, when you breathe out, it's like not having a mask on. So if you're using that mask to protect other people, not working. If you have an N95 mask that doesn't have an exhalation valve, it's protecting you both when you're breathing in and breathing out. Hopefully that's clear. If not, email me or call me, we can go over that. Can you wear a cloth mask over an N95 mask for better protection? Well, if you have an N95 mask that doesn't have an exhalation valve, you don't need it. If you have an N95 that has an exhalation valve and you're using that mask to protect others, you might as well just use the cloth mask. Sure, you can put a cloth mask over an N95 mask. It's going to get hard to breathe. I would assume. If the cloth mask is actually there doing anything, I think it would be a challenge. So you're better off just going to a cloth mask for lower risk things. If you're worried about yourself and you find an N95 that doesn't have an exhalation valve, that would be good. Are there guidelines coming up for emerge clinics? I guess I would turn the question back as what do you want to know? And because we can add things, alter things. I don't know of any emerge specific guidelines that are coming out, but we can certainly address specific areas that you don't think are well enough addressed. So anyone that has areas that they don't think is covered well enough, please let us know. I probably need to shut up now unless you want me to answer the last one.
We are at the top of the hour, so we're going to capture the remainder of the questions so we can address them next week. I wanted to say another big thank you to our speakers today, but also to Hill's Pet Nutrition for sponsoring this session, and we look forward to seeing you next week. Thank you, everyone.
And again, don't be afraid to follow up. Just I want to get up the Hill slide too quickly, but if you have questions, there's my email address. If you do want to follow up on any of these things, or if you think we have information gaps and educational gaps, let us know because that's stuff we'd like to try to address. Thanks, Melanie. Thank Catherine Hills.
Thank you.
Have a good day.
Bye.